Hi, I'm Rebecca Sturgis. I'm an M4 at Wayne State University, and my project is the appearance of Clivus bone metastases in metastatic cancer patients. Other authors include Doctors Mack, Maier, Kim, and Heath, and this research was conducted through Karmanos Cancer Institute in Wayne State University. Starting with the introduction. Metastases to the bone are most common in breast, prostate, kidney, lung, and thyroid cancers. The majority of patients with advanced breast and prostate cancers have metastatic bone disease. The clivus is a small area of the cranium located near the base of skull. Due to its proximity to cranial nerves, tumor involvement of the clivus is associated with neurological deficits such as facial numbness, visual changes, and tongue paralysis. Little is known about which patients are prone to developing clival metastases and whether there are indicators that suggest a patient will develop these clival metastases. There is also currently no optimal method for treating these patients. Our research is the first step in answering these questions. This is important because patients may not associate their neurological symptoms to their cancers, leading to a delay in treatment. So physicians must be aware of the link between neurological deficits and cancers in order to effectively treat their patients. To begin answering these questions, we conducted a retrospective review of patients treated at Karmanos from January 2000 to June 2020 who had a primary metastatic cancer and went on to develop clival metastases. The patients included were those treated at Karmanos who are older than 18 and had radiologic imaging available which demonstrated these clival metastases. Information collected included cancer type, neurological symptoms, prior imaging, treatments received, symptom response to treatment, and next-gen sequencing. Coming to the results, Table 1 demonstrates our patient characteristics. We identified 44 patients who had a primary metastatic cancer who went on to develop clival metastases. Out of the 44 patients, 23 received radiation treatment to treat these metastases, while 21 did not. Overall, the median age of the 44 patients identified was 62.5. The majority of the patients were male, while the majority race was white, followed by African American. The most common primary cancer identified was breast, followed by prostate, and then multiple myeloma. We also identified other cancers with clival metastases which were not as prevalent in our patient population, as shown here in Table 1. In terms of radiation treatment, we identified base of skull / clivus, whole brain, and cervical spine as the treatments available for treating clival metastases. In our patient population, the most common type of radiation treatment these patients received was base of skull / clivus. Of the 23 patients who received radiation treatment, the patients were again mostly white males, but the most common cancer that these patients had was prostate. These patients also primarily received base of skull / clivus radiation. Of the 21 patients who did not receive radiation treatment, the majority were white females, with the most prevalent cancer being breast cancer. Overall, 52% of the patients identified received radiation treatment, while 48% did not. If we move down to Figure 1, this is an example of a radiologic image of a clival metastasis. This image is an MRI of the brain of a 58-year-old patient with stage 4 prostate cancer who initially presented with headaches. He was then found to have a clival metastasis on his MRI, as demonstrated here with the orange arrow. Figure 2 below demonstrates his patient's radiation treatment plan. His plan included delivering 3,000 centigrade and 10 fractions using opposed laterals and 6 megavolt photons. The entire gross tumor volume, or GTV, is here outlined in yellow, and it received 3,000 centigrade, while 95% of the planning target volume, or PTV, is outlined here in blue and received 100% of the dose. Figure 3 right next to it is a lateral view of this radiation treatment plan. If we move up here to Table 2, this table demonstrates the most common presenting symptoms among the 44 patients we identified. This table also demonstrates how many patients with each symptom received radiation treatment or did not receive radiation treatment. Since many of these patients experience more than one symptom, it is important to keep in mind that they will be represented for each symptom they experience, since the table is based symptomatically. The most common presenting symptom in our patient population was headache at 30%, followed by diplopia at 16%, lateral gaze paralysis at 14%, and blurry vision and chin numbness both at 11%. Other less common neurological deficits were also experienced by our patient population, as demonstrated here in Table 2. Now, looking specifically at these most common presenting symptoms, of the 13 patients who experienced headache, 10 of them, or 77%, received radiation treatment, while 23% did not. Of the 7 patients who experienced diplopia, 86 received radiation treatment, while 14% did not. Of the 6 patients who experienced lateral gaze paralysis, all 6, or 100% of these patients, received radiation treatment. Of the 5 patients who experienced blurry vision, again 100% of these patients received radiation treatment. And of the 5 patients who experienced chin numbness, 80% received radiation treatment, while 20% did not. This data is also available for the other less common symptoms, as seen here in Table 2. Table 3 below demonstrates the effects of radiation treatment on each symptom. Again, we will look specifically at the most common presenting symptoms. For the patients who experienced headache, 10 of these patients had gone on to receive radiation treatment, as we saw above in Table 2. Of those 10 patients who received radiation, 8 of them, or 80%, had symptomatic improvement of their headaches after radiation treatment. For the patients who experienced diplopia and underwent radiation treatment, 83% had symptomatic improvement after radiation. Of the 6 patients who experienced lateral gaze paralysis and underwent treatment, only 33% had symptomatic improvement. Of the 5 patients who experienced blurry vision and underwent radiation treatment, 40% improved with radiation. And of the 4 patients who experienced chin numbness and underwent radiation treatment, 50% had symptomatic improvement of their chin numbness after radiation. The data for the other less common symptoms are shown below in Table 3, although some symptoms did not receive radiation treatment but are still included in this table for completeness. In conclusion, breast, prostate, and multiple myeloma are the most common types of cancers with metastases to the clivus we identified in our patient population. Of these 44 patients we identified with clival metastases, 52% received radiation treatment, while 48% did not. The most common presenting symptoms we identified are headache, diplopia, lateral gaze paralysis, blurry vision, and chin numbness. When we think about primary cancers like breast, prostate, or multiple myeloma, we don't usually expect to see these types of neurological symptoms. So if a cancer patient presents with these symptoms, physicians need to be aware of the association of clival metastases and neurological symptoms so they do not miss a clival metastasis diagnosis. And when these clival metastases are identified, radiation treatment should be included in a treatment discussion, since 58% of the symptoms in our patient population improved after receiving radiation treatment. Our research is still ongoing, and some of our most important future work includes evaluating the genomic profiling of patients with these clival metastases, since the clivus is not a common place for metastases to begin with. And due to the significant effects caused by these metastases, we want to know if there's a genetic reason for some patients being more prone to this diagnosis. Hopefully, this research will lead to better treatment options in the future. And below are my references. Thank you.